Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This Learn Shop is in 3 parts. The first part is about cardiovascular and respiratory physiology, but it's related to the consequences of aging, getting older. We all get older. Now the learning objectives are to review normal physiological changes that occur with aging in the cardiovascular and respiratory systems, then the consequences that occur, and the nursing management for people experiencing these age-related changes within the cardiovascular and respiratory systems. Now, this is the cardiovascular system. And the cardiovascular system consists of the heart as a pump and all the associated blood vessels. The aorta, the arteries, arterioles, capillaries, venules, veins, right back to the great vessels, inferior and superior vena cava, back to the heart. Now the heart's primary function is to pump. It pumps blood. And it consists of the right ventricle, left ventricle, right atrium, left atrium, with the great vessels being the vena cava, inferior and superior, and the aorta. Not to forget the pulmonary artery. The heart essentially has 4 chambers, and the 4 chambers are the right and left atrium, and the right and left ventricle. The right side of the heart is separated by the tricuspid valve, and the left side the mitral or bicuspid valve. And the exit point for blood outflow from the right side is the pulmonary artery and its valve, and the left side the aorta and its valve. Now the types of blood vessels that we have are the arteries, veins and capillaries, and what are their functions? The functions are essentially, for arteries, they're blood vessels that carry oxygenated blood with nutrients away from the heart to the body. Veins are blood vessels that carry deoxygenated blood with wastes to the heart, kidneys, liver and lungs from the body. The capillaries are the smallest blood vessels. They're only 1 cell thick, and they're the sites for transfer of oxygen, carbon dioxide and other nutrients from the blood to the other tissues. And as I just mentioned, they also collect carbon dioxide and other waste products. Now, the heart's external features, which I'm going to briefly review, are, I already said, the right atrium, right ventricle, left ventricle, the pulmonary trunk, ascending aorta, and the right and left pulmonary veins. We also have the right and left coronary artery, and we have the cardiac veins. The arteries are essentially 3. The right coronary artery, the left coronary artery, which consists of the left anterior descending artery, and the circumflex. The internal features of the heart, as mentioned previously, we have the right and left atrium, the right and left ventricle, the pulmonary trunk and valve, the ascending aorta and valve, and blood returning to the heart comes back via the great vessels being the superior and inferior vena cava. Blood returns from the lungs via the 4 pulmonary veins, and they enter the right atrium. The right atria and ventricles are separated by the tricuspid valve, and the left atrium and left ventricle are separated by the mitral or bicuspid valve. Now, when it comes to the heart, the age-related changes are typically associated with coronary artery disease. Atherosclerosis, which results in arteriosclerosis, which essentially is hardening, thickening, with loss of elasticity. And this can result in acute coronary syndromes such as unstable angina, which is non-ST segment elevation myocardial infarction, ST segment elevation myocardial infarction, and possibly because of aging and nerve dysfunction, a silent myocardial infarction. In relation to the heart and age-related changes, you can develop heart failure, left, right, or both. This can be as a consequence of systolic dysfunction, where the heart can't empty properly because of increased resistance, which we call afterload. Or you can have diastolic dysfunction, where the heart can't fill properly, and if it can't fill properly, this will affect coronary perfusion pressure, CVP. If it can't fill properly, it can't empty properly. You can develop valve disease, where the valves thicken and get stiffer, and as a consequence of wear and tear and decreased elastin, increased collagen through aging, the heart becomes more dysfunctional. Typically in the aged, the left ventricle becomes a little bit stiffer and hypertrophies and develops cardiomegaly. One of the consequences of heart failure is congestive heart failure, which typically combines both right and left. When we look at valve disease in relation to age-related changes, the valves thicken and get stiffer as a consequence of wear and tear, decreased elastin and increased collagen, and calcification. So this can be mitral valve stenosis or incompetence. It can also be aortic valve stenosis and incompetence. The valves thicken and stiffen because the left side of the heart has to work pretty hard from the time that you're born to the time that you are 70 or 80 years of age. Aortic valve stenosis, have a look. Problem whether it's open or closed. And the same applies to mitral valve stenosis. When it comes to the heart's conduction system, the heart's electrical conduction system, we have the sinoatrial node, the avioventricular node, we have the His-Purkinje system. And this is an important system to make sure that the heart is stimulated correctly and contracts effectively. Age-related consequences in relation to the cardiac rhythm or the electrocardiograph are loss of the SA node, AV node cells, which can result in what's called sick sinus syndrome or sinus dysfunction. It can also result in slower conduction, bradycardias, and heart blocks, which can be second degree or third degree AV conduction defects. In the worst scenario, you may develop asystole. Heart failure can occur as a result of atrial fibrillation, which can result in stroke or cardiac dysfunction and sudden cardiac death. Bradycardia in the form of certain heart blocks. Age-related third degree heart block, AV conduction defects. Atrial fibrillation, which can result in stroke. In the worst scenario, coarse ventricular fibrillation, sudden cardiac death. When it comes to the blood vessels, what are some of the age-related changes? Well, they're less elastic. You've got calcium deposits in the walls. Atheromatous plaques form. You get cholesterol accumulation. You get increased low-density lipoprotein cholesterol. Aneurysms can form. You can have a stroke. You can have a myocardial infarction. You can develop renal artery disease, peripheral artery disease. In this situation, this is the development of atheromatous plaques, which results in arteriosclerosis. As you get older, nitric oxide isn't produced as much by the cells. And nitric oxide is really important for vasodilation. And as you can see, as you get older, nitric oxide production decreases. When you're young and healthy, typically there are no problems. When you get older, the arteries become stiffer, harder, you become hypertensive. And as a consequence of that, you can get what is called vascular remodeling, which results in stiffness, inflammation, and calcification. So what's the major risk? As you get older in the aorta, the major risk is when you're more than 65 years of age. And typically it's as a result of athero- and arteriosclerosis. And this can result in aneurysms forming in the aorta. These can be thoracic, abdominal, they can be very, very close to the heart in the ascending aorta, in the aortic arch. Here are some examples where the aneurysms can form in the aortic root, in the ascending aorta, or they can be all over the place, fusiform. They can be thoracic, they can be abdominal. If an aneurysm ruptures, there can be a slow leak, and the hemorrhage can be contained in the retroperitoneal space if it's in the abdomen. Complete rupture results in massive hemorrhage, whether it's in the abdomen or whether it's in the thorax. Then you've got peripheral artery disease in relation to age-related changes. If peripheral vascular disease is only in arteries, we call it peripheral artery disease. These are age-related to, as we've mentioned previously, atherosclerosis and hypertension. And as a consequence, you can see peripheral vascular disease with pallor on that left foot in both images. And this will result in ischemia. Pulses will be affected. You can get necrosis, which requires amputation. So, peripheral artery disease can be related to the skin, the heart, the kidneys, the legs, the hips, the thighs, and the feet, and the toes. Other age-related changes may be in relation to the blood vessels and the aortic bodies. Remembering that we have baroreceptors in the carotid sinus and the aortic arch. And with aging, the cardiovagal baroreceptors, the reflex and sensitivity reduce. And this can result in postural hypotension. When blood vessels, the veins, are affected, this can result in venous insufficiency. And this occurs when the venous wall and the valves in the leg veins are not working effectively. And it makes it difficult for blood to return to the heart, venous return, from the legs, so the blood pools in the veins, and this pooling is called venous stasis. The stasis can result in varices. Look at the healthy vein, look at the diseased vein, and thrombosis can form as well. With venous insufficiency, blood doesn't return effectively to the heart. Results in varices and swelling and edema. There you can see varicose veins, swelling or edema, ulcer formation, skin changes, increased pigmentation, ulcers, varicose veins, edema, venous insufficiency. When we look at the nursing management of cardiovascular risks, the assessment includes uncontrollable risk factors, and they are getting older, unfortunately. You can't control that. Age. Gender, you can't control. Family history, you can't control. Being postmenopausal, and your race, you cannot control. They are all potential risk factors. Controllable risk factors, however, include being physically inactive. Get some exercise. Obesity, smoking, high, low density lipoprotein or bad cholesterol, low, high density lipoprotein or good cholesterol, hypertension which is under control, diabetes mellitus which is under control, and stress which is under control. So when we look at the nursing management, the initial management is obtain a health history. What's the chief complaint? What's the present problem? Past medical history, surgical history, family history, and social history. An example of getting a history is S.A.M.P.L.E. S, symptoms. What's the patient's chief complaint? Are there any allergies? What medications are they on? What's the past medical history? And what was the last oral intake? Just in case some intervention has to be planned. And what were the events leading up to the current problem? As we mentioned, this is the sample example of history. Symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the current problem. What's the chief complaint? Well, chief complaint is the medical term used to describe the primary problem that brought the patient in to seek medical attention. This woman has got chest pain. What are her signs and symptoms? The present problem: she's anxious, scared, has chest pain, is pale, has cold, clammy skin. Her past medical history is that she's a diabetic on insulin. She's hypertensive on beta blockers, atenolol. She's hyperlipidemic on a statin, atorvastatin, and she has stable angina, and she is an ex-smoker. For general assessment, you can use the patient assessment tool. Appearance: what's she look like? What's her breathing like? What's her skin colour like? With this tool, in the general assessment, you only look and listen. There's no touching, and it takes really about 15 to 60 seconds, not long at all, to establish whether she's stable, unstable, well, unwell, good, or bad. Then you can move on to the primary assessment. And in the primary assessment, you assess the vital signs: airway, breathing, circulation, disability, which means neurological, level of consciousness, or does she have pain, and exposure, temperature. A, airway and oxygenation. B, breathing and ventilation. C, circulation, and does she have any shock? Disability, what's her neurological status like? Exposure really is temperature. So specific assessments could be peripheral pulses, blood pressure, lying, sitting, standing, her pulse pressure, capillary refill time, skin turgor, her jugular venous pressure, and auscultation of her heart sounds. What's her weight? Electrocardiograph, chest x-ray, and echocardiogram if indicated. So, blood pressure, is there any postural hypertension? Here, capillary refill time, less than 3 seconds. Jugular venous pressure shouldn't be visible. Auscultation sites, S1, S2, first heart sound and second heart sound. Lub-dub, lub-dub, lub-dub. Weight should be within a normal range. So, when it comes to the nursing management of cardiovascular rehabilitation, this is done in collaboration with a multidisciplinary team, which includes the nurse, the physiotherapist, occupational therapist, dietitian, and a physician. And the objective is to enhance activities of daily living. And this may require lifestyle modification, maybe including exercise training. Education about weight loss, smoking cessation, nutrition, hypertension, controlling diabetes, watching your diet, and reducing your cholesterol. Or increasing your cholesterol, high density lipoproteins, the good cholesterol, and making sure that you follow medication. Stop smoking. Eat healthy. Take your medications as ordered. Also, When it comes to compliance with medications, you've got your antiplatelet agents, your anticoagulants, your beta blockers, your calcium channel blockers, diuretics, and anti-cholesterol agents. Anticoagulants like warfarin, diuretics like furosemide, beta blockers like atenolol. When it comes to the respiratory system, well, the respiratory system consists of the upper respiratory tract and the lower respiratory tract. The upper respiratory tract consists of the nasal cavity, the soft and hard palate, the nostrils, oral cavity, tongue, trachea, pharynx, larynx, and vocal cords. The lower respiratory tract consists of the larynx, trachea, your primary bronchi, right and left, become bronchioles, become the alveoli, and they end up involving all the lung. You also have the diaphragm as the primary muscle of ventilation. The alveoli are the site where you get alveolar and capillary interface, where oxygenated blood and deoxygenated blood are exchanged. The alveoli of the human lung have got a surface area that's equivalent to a tennis court. When you're born, you have about 300 million. When you're an adult, this is already exceeded to 600 million alveoli. As you get older, there's a gradual loss of alveoli. When it comes to age-related changes in the upper respiratory tract, well, you've got decreased activity of the cilia and the macrophages. So therefore this results in dry mucous membranes, decreased mucus or clearance of foreign matter, and a decreased cough reflex, which is a protective reflex. When it comes to the lower respiratory tract, you've got abnormal mechanics of breathing, decreased lung elastic recoil, and this affects expiration of air. You've got an increased functional residual capacity, FRC, which is the amount of air that is retained during expiration. And this could cause hyperinflation. Decreased surface area of the alveoli, which I said to you. I mean, you're born with 300 million alveoli. By the time you get to be an adult, you've got 600 million, but gradually, after the age of about 30, you start losing alveoli. You've got increased dead space, which means lung that doesn't participate in gas exchange. This can affect the vital capacity, which can affect the ability to cough. When it comes to the thorax, age-related changes can appear as decreased strength and endurance. You get tired breathing. You've got increasing atrophy and stiffness of the chest wall. This can result in musculoskeletal anomalies, such as kyphoscoliosis. You can have a decreased cough as a consequence of a decreased vital capacity. You can have decreased compliance in the upper and lower thorax. You may even develop chronic obstructive pulmonary disease, depending on what you've done in your youth. And this will result in more use of the diaphragm and abdominal muscles. Then you can have age-related changes which affect your chemoreceptors. Aging decreases chemoreceptor sensitivity, which means chemoreceptors in the medulla oblongata and the carotid and aortic arch, the peripheral chemoreceptors, won't be as sensitive to changes in carbon dioxide, oxygen, and pH. Chemoreceptors that are central in the medulla detect a lower or higher CO2, the PaCO2. The peripheral chemoreceptors in the carotid and aortic bodies in the aortic arch detect PaO2 and blood pH. And these affect your breathing. So as you get older, the decreased sensitivity decreases the response to hypoxia, hypercapnia, and acid-base anomalies. In the lower respiratory tract, diseases related to age can be emphysema, pneumonia, or pulmonary embolism. With emphysema, there's prolonged expiration, development of a barrel chest because of air trapping, increased functional residual capacity, increased mucus production, a persistent mild cough, and a decreased surface area for gas exchange. This results in hypoxemia and hypercapnia. Then you've got pneumonia, or an increased risk of pneumonia, with bacterial, viral, or nosocomial types of infections. However, this is typically associated with institutionalization, community homes, being immunocompromised, which can be related to aging, chronic obstructive pulmonary disease, and cancer. You can also develop a pulmonary embolism, which we've said previously was a sudden blockage of a pulmonary artery by a venous clot. And this can be related to deep vein thrombosis, obesity, a sedentary lifestyle, which you may have as you get older. What's the nursing management? Well, the initial management is as previous to obtain a health history. Chief complaint, present problem, past medical history, risk factors such as smoking, past surgical treatment, family history. What's the chief complaint? This man has got dyspnea. He can't breathe properly. It's a medical term that describes the primary problem. They've got the patient or the person to seek medical attention. Then his present problem, his signs and symptoms are that he's anxious, short of breath, has difficulty breathing, tachypnea, increased ventilation, he's got pink skin, which is a pink puffer. With emphysema, you get that. He has pursed lip breathing, which is classic, accessory muscle use, and he's really wasted. He has a barrel chest, and he's got decreased breath rounds, and he has hyperresonance on percussion. His past medical history, he's an ex-smoker, heavy. He has emphysema. Occasionally, he gets chest infections. In the general assessment, we look at the appearance, his work of breathing, and circulation. Looking, listening, no touching, evaluating very quickly over 30 to 60 seconds. And you determine whether he's stable, unstable, good, bad, well, unwell. In the primary assessment, we're assessing his vital signs, but primarily his airway and breathing. Airway and oxygenation, breathing and ventilation. But we still take note of his circulation, any neurological disability, and what his temperature is. In the specific assessment, we're looking at pulse oximetry, auscultating for lung sounds, his arterial blood gases, and the chest X-ray. Most important. Arterial blood gases. In this situation, the interpretation is chronic ventilatory failure, respiratory acidosis. His PaCO2 is high at 63. He's hypoxic with an FiO2 providing a PO2 of 52. His saturations are 86. Anything less than 90 is considered dramatic. Chest X-ray is showing chronic obstructive pulmonary disease, and he's got multiple blebs and bullae in his chest, which are like aneurysms in the lungs. He's got hyperinflated lungs as well, indicating air trapping, increased functional residual capacity, and we noted that he had a barrel chest anyway. What are some of the complications that can occur? Well, the complications that can occur are that you can develop subcutaneous emphysema, which means air in the skin, which can be seen on the puffiness of this man's eyes and on his chest x-ray, which is showing air in the neck and on the chest. Have a look at the Dr Manny Learn chops on chest x-ray interpretation. You'll see emphysema, subcutaneous emphysema, pneumothorax, and so on. Here, this isn't obesity, this is air in the tissues. He's got air everywhere. It's ruptured, the lung is ruptured. These are bullae and blebs, subcutaneous emphysema. What's the nursing management? Well, the nursing management for rehabilitation involves collaboration again with a multidisciplinary team, physician, nurse, physiotherapist, occupational therapist, and dietitian, and enhance activities of daily living. So do exercise, maintain a fluid intake, have a healthy diet, stop smoking. That's the important thing. Education and counselling involves coughing up secretions, breathing exercises and techniques, incentive spirometry, and medication compliance is most important. The conclusion is everybody gets older. It's inevitable. However, there are age-related physical and physiological changes. And with healthier aging, this is achievable. And it's achievable by adopting behaviours, interventions that reduce the risk of developing chronic diseases and prevent further injuries to enhance lifestyle. Okay, let's review now. 1. Can you name the blanked out external features of the heart? There are 2, 4, 6, 7. They are the superior vena cava, the right coronary artery, the right ventricle, inferior vena cava, left ventricle, and the left atrium. Name the arteries of the heart which are blank in the following diagram. They are the right coronary artery, left coronary artery, left anterior descending, and circumflex artery. Can you name the 6 generic vital signs? They are temperature, heart rate, which can be the pulse rate as well, the blood pressure, respiratory rate, oxygen saturation, and pain. Normally, you are pain-free. Can anybody name 2 age-related heart concerns that could affect the cardiac rhythm, the ECG? They are loss of SA node, AV node cells, which can result in 6 sinus syndrome, bradycardia, heart block, atrial fibrillation, and sudden cardiac death. Can anybody state the age-related concerns that could affect the upper and lower respiratory tract? Well, these are decreased activity of the cilia and macrophages, which results in dry mucous membranes, decreased mucus and foreign matter clearance, and a decreased cough reflex. In the lower respiratory tract, abnormal mechanics of breathing, decreased lung elastic recoil, increased functional residual capacity, decreased surface area of the alveoli, increased dead space, and this all affects vital capacity or your ability to cough. Thank you again. If you found these learn chops to be of any importance, please follow up, recommend them to your colleagues, and please look at the consequences of aging part 2 on YouTube. Dr. Manny saying goodbye.